Before I get started, of course, I have a comment about the elbow. So when you're talking about one or two approaches for these posterior montagia types, you have to understand if you use just the one incision, you're taking everything off of your ulna, right? So you have to take down your ulnar attachment of your lateral ulnar collateral ligament. So as long as you understand that you're doing that, and I'd also caution you for these posterior montasias, they very commonly have terrible triad component to it. They'll take off the coronoid and you'll already have a lateral ulnar collateral ligament tear off of the humerus. So you can really destabilize these things, and just trust me, I've done it. And so I try to do a separate interval to approach my radial head. It doesn't always work. Sometimes there's just all stripped off anyway, so you just go through the trauma. But do understand when you do that, you're taking down that attachment to the crista supinatoris of the ligament. All right, so we'll go ahead. So dorsal bridge plating's been around for a long time, first described in 1998, but around 2005, Doug Hanel, Seattle, really popularized it. It's also, you'll hear it called dorsal distraction plating. We'll talk a little bit about fragment-specific fixation, which has also been around for a very long time, these pin plates. This dates back for me like 20 years ago when I was playing with the paper clips. So anymore, the X-Fix is just not a real popular device for distal radius. It's certainly had its time and was very useful. But dorsal bridge plating has absolutely, in my mind, replaced the external fixator for definitive treatment of these distal radius fractures. The proof is in the pudding. There's a lower complication rate with the plates, which you can just imagine not having to deal with the pin complications. There's a decreased incidence of infection. You can leave it for a long time and not worry about it, which is the problem with the X-Fixes. If you get 8 weeks out of those things, then it's time to get them off. So the plates you can leave in for months, and typically we'll leave them for a good 3 to 4 months. It's a pretty simple method to treat these intra-articular fractures. I see a lot of my buddies just throw this plate on and they just sort of let the articular fragments fly wherever they go, but that's not kind of my technique. Anyway, it's also used for early weight bearing, which I'm still a little hesitant when you talk about weight bearing through 2.4 and 2.7 millimeter screws. That makes me a little nervous, but it has been described. So we'll just start off with the 18-year-old male, MVC, pretty high energy, has a tibia fracture along with this. And you'll see kind of once you get it reduced, all the components you're talking about, so intra-articular fracture, typical radial styloid, lunate facet fragments. The comminution that you'll see, I think for me, it just depends on how small these fragments are as when I start entertaining the idea of dorsal fixation versus volar plating. You can't tell real well from the splints here how much you have to work with, but I just felt that his intra-articular component was complex enough that for me to see into the joint, I need to go dorsally. So that's what I do, and I'll just put the joint back together however I can with some small plates, but realizing these small plates are not real stable. So this is what I use, basically the fragment-specific fixation for the articular component, and then we'll supplement it and protect our fixation with the dorsal bridge plate. Usually leave the plate in again 3-4 months with you. For me, one of the advantages of having the fixation internal that I'm going to leave, those small plates, I can get that bridge plate off by 2 months for sure, maybe even 6 weeks. So you can get them moving a lot easier, or a lot sooner if you have some internal fixation. This is kind of another similar kind of thing, but you can still see these fragments are very small that you have to work with. Get an idea once you reduce them how small these pieces are. And these are even small enough, I'm not sure I'm going to even be able to get any kind of screws into them. So again, I go dorsally, put my articular fragments back together as best I can, and if I feel all I can do is get K-wires in there, then that's fine. I just leave the K-wires, and then we'll supplement it with our bridge plate. So the exposure for the dorsal approach goes through the third compartment. I'll reduce them, bridge plates versus K-wires to get the articular fragments back together, and then supplement it with our bridge plate. So one of the questions that you kind of come to with the bridge plate technique is, do you do it before or after your joint reduction? I tend to do it afterwards, just so it doesn't get in the way of my reducing them and being able to see it. But I know people that will put it on to help them align it and get some distraction on it. Some people do it without any internal fixation at all. I kind of think of the bridge plate as a macro reduction tool, and then the articular pieces we're putting together with some small screws, plates, or K-wires, whatever. Next choice is whether you go to the second metacarpal or the third metacarpal. I don't know, in my institution, there's more people doing it third metacarpal, so of course I have to be different and go to the second metacarpal. Just ornery that way, I guess. But I do like the second metacarpal because it puts your hand wrist in a little bit of ulnar deviation, which always tends to help me. I like going through the second compartment with the plate versus the fourth compartment with all your extensors. I mean, it's tight in there to begin with, so I do prefer having the plate go through the second metacarpal. And I also feel it sits a little more radial, so you can actually see the articular fracture a little better in this area on your x-rays. Plates, I mean, I don't use a lot of different bridge plates, so I'm not sure what all is out there right now, but the ones I typically use have 2 4 screws in the metacarpal and 2 7 screws in the radius. So when you do go to the proximal part of the plate, make sure you can see the dorsal sensory branch of the radial nerve when you expose it. One of the questions is how much distraction. You shouldn't really need a lot of distraction unless you don't really have any internal fixation, and then I would probably tend to put a little bit more. But these are the incisions for the bridge plate. She's a lady that I was just doing some percutaneous pin to hold things, and then placed our bridge plate. So second metacarpal, you don't really even deal that much with the tendon. The tendon sits a little more ulnar to where the bridge plate sits on the second metacarpal. Down here is where you need to see, you're basically right around the outcroppers where it goes over the top of your second compartment tendons, and you should see the radial nerve when you're in there. But this is her after getting K-wires out, and usually take those out around 4 to 6 weeks. We'll leave the plate on. If something like this, I'll probably leave the plate on closer to 4 months, because you have nothing left in there. You have to make sure this fracture is healed before you take this plate off, because there's nothing left to protect you. You can see it's not a perfect reduction, but it has a decent platform, and they do tolerate some displacement a little bit. High energy fractures, so these are ones that kind of get people a little nervous trying to get these back together. The small articular fragments are a little hard. These are ones that I took over for my partner. They basically just put the plate on and don't worry so much about getting the articular reduction, and then they can pass it off to us, whoever is a little more interested in taking care of these injuries. But I'll always supplement the fixation with some sort of internal fixation, hopefully. Another reason to use the plate is to control radiocarpal instability. So even for some of these volar Barton type fractures, if you're not confident that you have good fixation, pieces are small, just add a dorsal bridge plate and it will hold your carpus reduced while you're letting everything kind of sock in. Osteoporosis, so I think it is used a lot in just the elderly population, that you just splint it out to length and let them heal where they want. The complication rate's extremely low, so reportedly 13% total complication rate. Hardware failure is pretty uncommon, 3%, non-union 3%. To me, I've seen non-union, probably the hardware failure where it pulls, the screws will pull out. Metacarpal is not that uncommon, but I have seen some non-unions from these, and I think people tend to over-distract it, so you have to be careful not to do that. You don't want to gap your fracture because it can induce a non-union. Tendon adhesions is also described. Fragment-specific fixation, this kind of came about with the pin plates and this use of the three-column concept for the distal radius fractures. You have the radial column, the intermediate column, then the ulnar column. But we basically do the same thing nowadays, it's just you use plates instead of these pins. So another intra-articular fracture we'll see. I've tried to piece things together best I can with some provisional K-wires, and then once you're in there, decide if you have fragments that are large enough to handle screws. And the plates get pretty small these days with the mini frags, so we can often get some plates and screws in these. Another 28-year-old, this is more of a, you'll see the intact volar rim of the radius here. So this is more of a dorsal Barton, involves the radial styloid. So we did just kind of a different approach, go more dorsal radially to approach this, and again, just some small plates to do your fragment specific. Also remember the pin plate trick for some of these volar rim fragments. There's an actual very small volar lunate fragment here that you need to be aware of, and you can use these small K-wires and just tuck it underneath your plate at the end. We'll be seeing more of this a little bit later. One useful technique I'll tell you is use small wires like 035 wires, because you have to really bend them down, and if you use something like a 1.25 or God forbid 1.6, you can't really bend them very well. So use small K-wires when you're using this technique. This is kind of the ultimate 57-year-old female motor vehicle collision, very, very, very high energy injury, just kind of a tatered mess here with the distal radius, but she also has all this other stuff going on, distal ulna, segmental ulna. So we just start trying to get some link stability with plating our long bones with the ulna, and then start working on the articular surface of the radius itself. So again, felt like we could use some small internal fixation. I didn't feel like I had enough bone to work with for the kind of a typical volar locking plate. So with these small plates, you just need to supplement them, in my mind. And so after all is said and done, has her dorsal bridge plate on with a whole bunch of other stuff. And yeah, probably didn't get her radial inclination as perfect as I would like. But all things considered, she healed up reasonably well. She's stable, and she had flexor tendon injuries too. So I was actually pretty happy with how she turned out. Not everything goes as planned. So this is a 61-year-old guy. I give him credit. He's a hard-working guy. Falls off a ladder, high energy distal radius fracture. Kind of seen it already. We'll put some articular pieces back together with K-wires, do our dorsal bridge plate, have him come back. We'll take out his K-wires in the office. After the K-wires are out, we got this x-ray probably another month later, and you can see kind of the development of a non-union. So I told him we need to go back in there and do something for this non-union. He disappears. He basically, he just couldn't afford not to work. So the next time he shows up, he looks like this. So it's a little different situation now. What just scared me the most was just all this bone loss in the metacarpal as well as his radius. So we didn't have any option, obviously, but to fuse him at that point is just a much bigger dorsal bridge plate and take out his ulna. He did pretty well and went back to work. So it's hard to fault the guy. He was just trying to make a living. So anyway, just remember kind of these fragment-specific fixation for these multi-fragment, especially intra-articular distal radius fractures. The consider a dorsal approach to get to your joint to deal with these intra-articular components, and then you can always supplement things with the dorsal bridge plate.